if you're losing your hair, don't assume that it's necessarily pattern hair loss or androgenetic alopecia, even though that's the most prevalent. There are other forms of hair loss that require different treatment.
Yeah.
And it's not always as obvious as one would hope. And that's the reason to see an expert, have them take a look at the scalp if you're not responding to treatments in the way that you would think you probably should be. I will tell you, and you hear people say this, and I always thought this was like very trite, and I never, believed it to be true until it's happened for me. When you're having fun doing what you're doing, or when you enjoy it, it does not feel like work.
Hello, everyone, and welcome back to yet another episode of the HairStacks podcast. Today, we have another special guest that's going to be the subject of our interview. And I'll now ask them to introduce themselves.
Kyle, thank you so much. I'm Reid Waldman, co-founder and CEO of Veradermics. I'm a board-certified dermatologist by background, and prior to founding the company, my focus was primarily in clinical research. I have more than 100 publications. I've been an investigator for numerous phase 2 and phase 3 studies, and I even wrote a textbook. Super excited to be here and to be chatting with you today. I think, as you know, we met through the Trestless forum on Reddit, and very exciting to finally actually get to have a detailed conversation.
Yeah, thank you. And, let's get started. So let's start off with the first question. VDPHL01 seems to be the lead treatment in the Veradermics pipeline. In the early days of this treatment's clinical trial announcement, what initially could be derived was its patent. So we had a lot of people looking at its patent and making, I guess, some assumptions. And this led to many, including myself, assuming that VDP, I'll just say that for short, contained several actives. So can we get an understanding of what this VDPHL01 is?
Yeah, absolutely. So VDPHL01 is a minoxidil extended release tablet. So minoxidil is the active ingredient. The idea being, I think everyone listening is familiar with existing oral minoxidil, which is a blood pressure medication. And so as we'd studied minoxidil, the pharmacokinetics, or the way in which it performs in the body, are exactly what you would expect for a blood pressure medication, where when you take it, its blood levels spike rapidly. Within 2 hours, the majority of it's gone. Within 4 hours, almost all of it's gone. So we saw that there was a mismatch in the potential of oral minoxidil and how the current pharmacokinetics of the existing blood pressure medication worked. Namely, as you would expect for a blood pressure medication, it had dose-limiting cardiac effects, meaning, right, the more blood pressure medication you give, the more cardiac effect you get. That's why you see that typically dermatologists do not escalate above a dose of 5 milligrams. And then furthermore, because we give, right, these sort of baby doses of minoxidil that are not around for very long, we see a hair growth ceiling with the drug, where the best data would really say that 5 milligrams of oral minoxidil is only as good as topical minoxidil 5%, or really, as I think most of us know, not very good. So with VDPHL01, we've aimed to optimize minoxidil for oral administration, hair growth, and cardiac safety by developing an extended release tablet that uses a proprietary gel formulation to slowly release minoxidil. The idea being that we believe that we can sustain concentrations of minoxidil throughout the day above the levels at which it grows hair, while staying below the threshold at which it has cardiac effects. Ultimately, right, we've translated this into phase 2 and put out preliminary phase 2 data recently, where we showed that pharmacokinetic profile translates into a hair growth profile that is fast, with visible results as early as 2 months, that is consistent with an extremely high rate of patient-reported outcome, clinically meaningful response, and that is intense with hair count changes, non-vellus hair count changes, using a digital image-based tattoo, endpoint approaching 50, all while having convenience of oral administration and maintenance of great tolerability. So, again, in short, right, this is a minoxidil extended release tablet. There are no other active ingredients.
Okay, thank you for that, explanation. That actually took out the next question that I had, so that's really good. Let's go on to the next question over here, and I'll ask, when observing some of the Veradermics data, it seems to me that the 4-month mean gain in hair count looks very strong. So does that come from bigger gains in classic minoxidil oral and or topical responders? So people who, I guess, who traditionally already respond to minoxidil, or is that coming from lifting a larger percentage of subjects into the minoxidil responder category, or could it just be somehow a mixture of both?
So I do think it's a little bit of both. And why do I say that? If you look at the patient-reported outcome data, as well as the investigator assessment data, you can see that at month 4, 90.5% of patients responded. Now, in addition, you may say, well, was there just patient exuberance about participating in a clinical study? Because sometimes we do see that where patients are more excited about study participation than what results may actually show. Well, as we presented at the EADV, we had 3 alopecia experts who were blinded to treatment, so they didn't know what they were looking at, and then they were shown image pairs and blinded to baseline. So they didn't know which was the before after photo. And the reason you do that is because if someone can appropriately identify the baseline, then you can say there's actually change between the images. And those individuals who are blinded, Jerry Shapiro, Kristen Losico, Marianne Sinna, they actually rated the photos remarkably similar to those patients. Having said that, I think more than 8 out of 10 of the patients achieved moderate to great improvement. So I do think that consistency is a big element, but then also the intensity element. And you
Mm.
go, well, why do we think the intensity element of response as well? Well, if you look back to, oral minoxidil 5 milligram data, and I talk about 5 milligrams again because I think that's really the upper use for most dermatologists. The best data would say that fewer than 25% of people taking that as a monotherapy get more than slight regrowth. And that data is also consistent with that expert blinded greater review that we conducted and presented at EADV. And so, whereas, as mentioned, we're seeing closer to 8 out of 10. So again, I think you're driving consistency, but also intensity of response in these individuals.
I think you make a good point when you mention monotherapy in particular, because I remember the study you're talking about, the 5% topical minoxidil comparison to 5 milligram oral minoxidil. And, there didn't seem to be any sort of statistical significance to actually separate the two. But, just speaking about that real quick, with oral minoxidil, the sort of issue that I have is that, at least, I'm talking about regular oral minoxidil, people typically aren't just using oral minoxidil. So whenever they talk about their changes on 5 milligram, it could be attributed to maybe using a 5-alpha reductase inhibitor, right? Like maybe finasteride or dutasteride. So yeah, it's kind of a bit of a huge debate right now. I know there are some studies coming out that show like 2.5 milligram oral minoxidil is efficacious against 5% topical minoxidil. But from what I remember from that particular study, I can't remember the author's name. It doesn't, I think the sample size was a bit small there. So,
Yeah. No, I
but
mean, I think
yeah.
I
Mhm.
think this is a really good point. So I think, one, importantly, in all of our clinical studies, we are testing monotherapy, and patients have to be sufficiently washed out of any background therapy, meaning you can't have taken Propecia for 6 months before entering the study. You can't have had a hair transplant in the past. All of these confounding items,
Yeah.
because you say something that is really important. So I think one thing that's challenging when we look at the literature for hair, or I would encourage anyone to be skeptical kind of when looking at the literature, is a lot of it is retrospective in nature, and a lot of it relies on patients who are on combination therapy. And when you have someone on multiple drugs, there is no way to know what's driving side effects, what's driving changes, what's driving profile. And so, yeah, monotherapy studies are critical, and we're always studying monotherapy, and the data we put out is always monotherapy.
That's great to hear. That's really good to hear. So, I guess as a sort of follow up to the previous question, do you expect the biggest improvements around month 4 with smaller gains after that? Or do you expect, at least from the data that's been gathered thus far, the treatment and the placebo to keep separating, let's say, up to month 12 and beyond?
So the short answer is we don't know at this point. We do know that placebo continues to get worse over time, obviously. And I think one big lesson from the Propecia work was that in the Propecia phase 3 studies, at a 6-month period, right, the hair counts in the placebo group had decreased. And when you look at the crossovers, right, everyone in the Propecia study, like in our phase 3 studies, after a 6-month period of time, goes on to active drug. You actually see that those in the placebo group never reached the peak hair counts that were achieved by the people who were initially put on active, suggesting, right, that delay in treatment or delay in the right treatment can delay eventual gains in this condition, even just a 6-month delay. But yeah, the short answer is we don't know where does it tap out, and what is the exact rate at which the placebo group will lose hair.
Okay, that's an interesting point. Next question would be, what limits did you, as in Veradermics, put on age, how long someone's had androgenetic alopecia, or baseline miniaturization, so the short-term results wouldn't look too good just because of who you enrolled?
Yeah, so this is actually a really interesting point. So as far as I'm aware, we have the oldest group of patients that have been included in a regulatory study, meaning that our age criteria is from age 18 to 65. Now, for context, Propecia was 18 to 41, Rogaine foam was 18 to 49. And I think, as most people know, there are two elements that are significant to including people over the age of 40. One, it's thought that they don't respond quite as robustly to hair growth treatments as a younger population. But two, you get a better characterization of safety in an older population who is
Yeah.
more prone in general to having side effects. So I guess that's an age perspective. The next question becomes about duration of disease. So we do not have any limiters on duration of disease outside of just how old you are. And then final is about baseline miniaturization. So this is really a good question that raises, I think, an additional question, which is how do you count or how do you measure miniaturization? So in a study like ours, like that uses what are intended to be regulatory endpoints, uh, we measure miniaturization or we measure non-vellus hair count by using a tattooed and then clipped and digital image analysis based hair count, meaning that, right, we tattoo an area in one's transition zone so that we always know we're measuring the same spot. We clip the hairs so they can all be visualized. We take this close-up photograph. That photograph then goes off to a third-party vendor. Now, that vendor is blinded to the study, they're blinded to the treatment, and they then have the digital image analysis count the number of hairs greater than 30 microns, i.e. non-vellus hairs, and then two humans do quality assurance review on top of that. Why do I say all of that detail here? Well, one, when you hear people talk about, hair counts in general, you should always make sure if you're trying to compare data to a regulatory treatment that it's this type of hair count. But two, what that means is we actually can't select for baseline miniaturization because we don't get a baseline hair count until after the patient has entered the study. And so
Hmm.
there is no limiter related to how much miniaturization the person can have in that area. And that again, that comes after they've already enrolled into the study.
I will say that looking at some of the pictures from the release that you guys had, those were some really impressive results. And I would, just as just my assumption, but I would make the assumption that, if you have someone who's like 45 with significant Norwood pattern hair loss, it's probably the case that they've been dealing with a consistent rate of miniaturization for some years. And to see like the recovery picture, it's insane. And maybe I'll have the editor like, put it up over here at some point. Those recovery images, it makes you question a lot of things, particularly when it comes to minoxidil. Again, at this high dose, but it being an extended release, so slowly releasing into the plasma.
Yeah, I mean, it was very encouraging to us to see people who are 5 get their hair back or grow hair back, I should say.
It also gives the question on, well, are those hairs ever really gone? Right? Because if you're looking at someone who comes in with their crown just seemingly depleted, maybe they have a tiny bit of vellus hairs if you look closely. And then, after like, let's say 6 months or 12 months or so, they have this tremendous recovery in that area. It kind of like, questions a lot of what we know when it comes to hair follicle biology and specifically for this, pathology of androgenetic alopecia. So it's really cool to see those follicles kind of revive themselves and not be vellus, either being intermediate or just full-on terminal hairs.
Yeah, I mean, it is super interesting, and you raise a point that I think is been a hot topic in the derm literature, which is right? There is a famous hair loss expert at Duke named Elise Olson, and she coined the term follicular depletion, right? The
Hmm.
idea that eventually in androgenetic alopecia, that you see a destruction of the follicular unit. Like if you do a biopsy of one's scalp, that that follicular architecture is no longer there over time. At which point it's irreversible. And I think we've seen with some discussion about therapeutics of, oh well, are they growing hairs where there wasn't hair previously, which obviously is ostensibly the goal of any hair loss treatment. But that I think what you're getting at is sometimes just because we can't visually see a hair doesn't mean there's not something to recover in that area.
Yeah.
And that similarly, just because hair regrows in that area, I would never want someone to think, oh, are these guys saying that there's follicular neogenesis with minoxidil? Because we obviously we don't believe that to be the case. And I do think even with great data, there are some people who will be too far gone where you see, a Norwood Hamilton 7 that really has a shiny scalp. I do think you see more of that true depletion. But it's hard to know in an individual how much recoverable hair there is until they treat.
That's true. Yeah. And, that goes to many people in the audience. Like, you only know your results if you try, right? Like, it's
Yeah.
pretty hard to just say, hey, predict this. It's like, you can't really know, right? Maybe,
No,
I don't know,
yeah.
if you do a biopsy, you can see things like the erector pili muscle, if it's actually still connected to the follicle. I think there's been some talk about that. Maybe I think Rodney Sinclair had a paper discussing exactly that. But even that, we just don't know much on
Don't know.
what is
Yeah.
recoverable.
And I think that that's one of the things. I mean, as we put out more photos over time, is for people to see these different, hair patterns, these different scalp types, people of different ages, and to see, yeah, that there is some degree of, right, you don't know until you treat. And obviously the earlier you treat, we would anticipate, like all therapies, time is hair, that the earlier you can get in and treat, the better.
This is just a question I thought of right now, but would you say the challenge as to why we don't know much of this information is due to, I guess, in my opinion, the lack of biopsy data within the literature? Because I talked to Dr. William Rassman maybe
Yeah.
around a year ago, and we were talking about conditions like lichen planopilaris and how it was once thought to be a woman or female only condition, particularly affecting women who are, postmenopausal. But he mentioned to me that some of his friends, his colleagues, particularly Dr. Shaver, in their clinic, as they do more biopsies of younger men or just men in general, they've uncovered that the lichen planopilaris rate is higher in their clinic than what is reported in the literature. And you can only have what you're recorded based on what you're actually looking for. So if we typically think that hair loss in women indicates a more severe issue, underlying issue, then I think some clinicians are more inclined to run further tests, whether it's blood tests or even biopsy data. So
Yeah, I mean,
I guess to
this is
kind of bring the question, do we just not have enough biopsy data that can help us know whether or not a follicle is recoverable?
So, I mean, this is a really interesting topic. And I will say this has become a big topic in academia as well, on two notes. So, one, next week there's a big hair conference called the Alopecia Summit that the American Hair Research Society puts on. That's in New York. And you'll see that there are numerous hair pathology lectures. And one of the big trends there has been this idea that in androgenetic alopecia, we do see, peribulbar inflammation in a subset of people, which you would think of in
Oh,
lichen
wow.
planopilaris, as you mentioned. And there's this question. So we're talking about like microinflammation around the hairs, and you're going to see that there's going to be more data coming out on that. That there's going to be more literature in the academic world there. So I think that's thing number one. I think thing number two that you mentioned that I think is important for people looking at data to understand is that retrospective database data is only as good as the way in which you record data. And so one thing I always point to there is like safety data, for example, that when someone does a retrospective chart review to look at safety data, right, they're looking at people's office notes. And, I'm sure if anyone's ever read their visit note when they see a doctor, they read it and they go, oh man, there's not a lot here. It's pretty sparse. And so it may be that either you just don't come back for a follow-up visit because you had a side effect and then you didn't want to be on the drug, and we don't know that, so it doesn't get recorded. Or you said, hey, I had, X side effect and I want to do something different. And all they put in the note is, oh, well, we're going to change the drug, because that's really the material thing from the note perspective, is we're stopping one drug, we're going to the other, and they may not record all of that ancillary detail. And so I do think that, as you put it, database data of any kind is only as good as what is recorded in said database. And it can make retrospective data extremely difficult to interpret. And I mean, yeah, in the LPP category in particular, I mean, think about it. In FFA, right, a subset of LPP, we didn't even know existed until 1994. Just
Oh
crazy.
wow, yeah, yeah. That's it's major. I guess moving on to the next set of questions, we're going to be getting into the topic of the pharmacokinetics and dynamics in relation to Veradermics and this, I guess, cardiac threshold concept. So, my first paired question would be, what empirical data did you or Veradermics use to set your cardiac safety peak plasma level limit? And how much variability in peak plasma level is acceptable across, I guess you can say, fed versus fasted conditions and different BMI groups? So, to put it simply, could something as basic as eating a meal meaningfully change the peak exposure?
Yeah, so this is also a great question. So I think first, we'll talk about what clinical data supports the cardiac threshold. Then we'll talk about how do you model for variability, like what you just mentioned, when trying to determine that something stays below a threshold. And then third, I think it's important to tie in the mechanism of minoxidil, and that'll get a little scientific, but I think some people might find it interesting, and how that
Yeah.
ties to this threshold-based argument. So first and foremost, right, the cardiac activity threshold is something that is recognized by FDA in the summary basis of approval for the Rogaine products. And it was developed in the 90s during Rogaine's over-the-counter switch, right? Rogaine was a prescription drug that then went over the counter. And the story is supposedly that the FDA had, potentially become concerned that when a drug goes over the counter, right, people can buy as much of it as they want. Well, would people put this all over? Would it get absorbed? Would something bad happen? And so they needed to show that there was an adequate safety threshold versus the exposure with Rogaine, even with overuse of Rogaine. And so they took 41 individuals with uncontrolled hypertension. Why uncontrolled hypertension? Because they're known to be more sensitive to the cardiac effects of minoxidil. They then gave them intravenous infusions of minoxidil. So they sustained these infusions for 12 hours. And for those of you who don't have a PK background, right, that means it's like a flat line from a blood level. And they did that at ascending doses. And they did that until they could find a dose at which the first sign of cardiac effect occurred. So not a symptom, not an adverse event, but a sign. And that sign is a heart rate increase greater than 5 beats per minute. And that occurred at approximately 20 nanograms per ml, with the belief that if you stay below that, that there's a reduced risk of cardiac effects. That is then further supported by oral minoxidil data that was generated to support, at the time of Rogaine's development, its safety. So they wanted to say, well, where, when you take it orally, do you see cardiac effect? And we're talking in averages here. So I think always we talk about averages. I want everyone to know that, like, you can have outlier exposures, things like that, absolutely. And there's always cases of things, but this is on average. So on average, if you give someone a 5 milligram immediate release tablet of minoxidil, you will see heart rate change in a normotensive individual, right? Someone who has normal blood pressure, and you will see a reduction in blood pressure in someone who has high blood pressure. How do you know that to be true? Well, the drug, if you look at the package insert for the blood pressure medication, is approved starting at doses of 5 milligrams. If you go to 10 milligrams, you see a blood pressure reduction in both individuals who have a normal blood pressure baseline as well as those who have high blood pressure. Um, Tying that back to the cardiac threshold, an individual who takes a 5 milligram immediate release tablet gets, on average, approximately a peak plasma concentration of about 28 to 32 nanograms per ml. So it ties back to kind of what we talked about. So this is a conservative safety threshold. It then raises the question of, why is there a threshold at which there are cardiac effects? Like, why would this make sense that you have to reach a certain plasma level to have a cardiac effect? And if you think about how minoxidil works as a blood pressure lowering agent, it works not only as a vasodilator, but it vasodilates by opening potassium channels in the smooth muscle around your arteries. And when it opens those potassium channels, that then changes the ions, right? It changes the charge within those smooth muscle cells, which then has a downstream effect on what are called voltage gated calcium channels. So those channels, right, require a certain charge to open or close. And when you affect those channels, then you end up getting actually relaxation of the smooth muscle. I know that that is like very scientific, but my reason for saying that is any time in the body you're dealing with these charges, you have to reach a critical threshold of the charge changing in order to see biologic effect.
Thank you. That's a really, really good and detailed explanation. I guess one last point, because it was from, some people asking this question in regards to fed versus fasted conditions and different BMI groups. Did that have any sort of impact on this modeling?
Oh, so you always model for these types of effects. So anytime that there's pharmacokinetic work done and you're working around a threshold, you do what's called population PK modeling. And so you take any of these, major features, like you mentioned, height, weight, et cetera, and you model based on, right, the CDC has data as to what the span from like the first to 99th percentile of the US population looks like, and you model around those to make sure that you have an appropriate threshold. You would not want to say, well, in our 12 patients, the average person got to 19, so it's probably good for a million other people. That's not a safe way to think about this. You have to consider those sorts of factors, and you do this what's called population pharmacokinetic modeling. Absolutely.
Okay, thank you. So moving on to the next question. Does VDPH Oh, sorry. You see, these acronyms get to me. I'm just trying to,
It's
put
such
them all
it's such a
together.
tough acronym, and I'll tell you the VD is for Veradermics and PHL is for pattern hair loss. And just so
Okay.
people know, we use the term pattern hair loss internally, just because in women we're not convinced androgens play a role in hair loss, and
Really?
so we think pattern hair loss. Yeah, I know it's a controversial take, but that's
Okay.
and we could talk about that too. It's one of my favorite topics of conversation. So we use the pattern hair loss name, and that's why it's in our moniker.
Yeah, I was gonna get on with this question, but I actually we'll touch on that after. Maybe this question was probably already answered. I was gonna ask. I'll just say VDP. Does a VDP aim for the same overall exposure but lower peak levels, or higher overall exposure while keeping peak levels controlled?
Oh, so this is a great question. So we try to give more minoxidil for longer while avoiding peak spikes and avoiding accumulation with repeat dosing. So it is both give more overall exposures, improve the consistency of exposures, and then reduce those peaks. And we believe that the more minoxidil for longer, drives its hair growth effect while avoiding those peaks is what has the potential to reduce cardiac risk.
I see. Okay, so before we even talk about the theories on women and their AGA or their pattern hair loss, I'll just ask this question real quick. So I guess why the high dose with VDP, and why I think from what I remember, it's used twice a day. I'm not. It's at 8.5 milligram, or I mean, maybe you can cut in and correct me on that, if whether or not it's used once a day or twice a day, because some critics have questioned if they can get the same improvement as seen in the Veradermics photos by simply taking a large base dose, say of let's say 10 milligram, or a minoxidil, where they split it into something like 5 milligram in the morning and 5 milligram at night, or perhaps even smaller doses, as annoying as it might be, throughout the day at more variable hours.
So that's also a really good question. So yeah, as you put it, we're studying 8.5 milligrams once daily and twice daily in our ongoing phase 3 program. And I think many people say, well, what happens if we gave all that drug at once? And there's two things to think about. So one is the safety element, the other is the efficacy element. So from a safety element, if you took 20 milligrams of minoxidil, which we have given to people previously, I mean, that is a bona fide cardiac dose of the drug, and I would definitely not recommend taking that all at once, even if you have baseline normal blood pressure. But even with that in mind, from an efficacy perspective, uh, we're not convinced, and I think the medical literature would not support that giving it all at once is going to give you the benefit that you would want. And you go, well, why is that? So I think as we, and I guess first, just the clinical data there. If you look at a recent study in the Journal of the American Academy of Dermatology, Paulo Ramos, who's a great alopecia expert in Brazil, put out a study comparing 5 milligrams even to 2.5, and did not see major delta there. And I think you go, well, does that mean more isn't better? No, it doesn't mean that. It means that when you just drive the spike of minoxidil, which when you go up on an immediate release dose, what you are doing is you are driving the peak. It probably does not give you the durability of target engagement as well as the ability to sulfate the drug in the way that you would hope so. And so that your amount of, active metabolite minoxidil or minoxidil sulfate at the hair level is impaired. And then your duration of target exposure, right? The duration of time that the drug is in the follicle is impaired. So you don't get the degree of benefit you want. In terms of, could you take, a milligram of minoxidil 10 times a day for the rest of your life? I mean, yes, I think you could, but I think that's rather impractical.
Yeah, I mean, if people already have issues with applying, topicals, taking a 1 milligram, every other hour would be kind of
Would be a
annoying.
little challenging, yeah.
Yeah,
And if you could do it, I'm impressed. I guess that's the short answer.
I think you might need a timer for that, like a reminder of some kind. But I'm gonna, break from the line of questioning. I'm just curious. When it comes to female pattern hair loss, or I guess pattern hair loss in general, you guys don't think it's mainly driven by androgens, or it's something
In
completely
men, it
outside of
definitely is.
androgens?
So in men, there is no doubt, right? The role of DHT is undeniable, absolutely.
Okay,
In women or in female pattern hair loss, you go, well, why do I say we should call pattern hair loss not androgenetic alopecia? There are really no good studies showing that androgen modification in females has the impact that you would hope, like it does in males. And what do I mean specifically there? Well, first and foremost, many people don't realize that the reason that Propecia is not approved in female pattern hair loss is not because of the teratogenicity, which is what a lot of people point to. It's
I
because it
see.
didn't work in phase 2. So female pattern hair loss, they studied over 100, females in the 90s, and they did not show benefit. Now, then furthermore, so that's DHT. That's not a true androgen blocker. More recently, we saw topical monoxide, or topical clascoterone, which is a non-steroidal anti-androgen, studied in the female population in a phase 2, and it didn't appear to work. And so I think there's some question as to whether you get efficacy. The final one is even more recently than that. There has been evaluation of an extremely potent oral non-steroidal anti-androgen, bicalutamide, what is
Yeah.
branded as Casodex, right? It's used for androgen-sensitive prostate cancer. Has been studied in female pattern hair loss in a prospective manner with hair counts, and it didn't seem to show benefit. And so I think there is some question whether anti-androgen therapy in female pattern hair loss has an effective role. Now, you see a lot of spironolactone use, obviously, and there is no prospective monotherapy data with spironolactone. But I think that this opinion that I'm expressing is actually becoming much more popular in the academic hair loss community among dermatologists, given that there is this mounting data that when you block androgens, you maybe don't get the treatment effect that you would want.
So, are we saying this is related to female pattern hair losses? So, like the conventional Sinclair scale or Ludwig scales, because the I don't know, because I've seen some photos, right? Some pictures where women have had what we would conventionally think is a male pattern style of hair loss, right? And I've also seen that sort of hair loss pattern, female pattern hair loss expressed in men as well. So, is it the case that a woman that has hair loss, um is there ever a woman with androgenetic alopecia? Let's just say that. Is that ever
I
a
don't know.
possibility?
So I mean, I would never speak in absolutes. What I'm saying is in large scale regulatory studies, we haven't seen the benefit. And it makes you question, well, why is this happening? And I'm sure a lot of people saw in the New England Journal of Medicine there was just an article about
Yeah.
female pattern hair loss, or I think they called it hair loss in women. And I think that one of the conclusions is there's a lot more that needs to be learned. There's a lot of specific study there. And I think a question that often comes up is, what is going on there? I think the final comment I'll make that is kind of interesting is, as many people know, or we take global photographs of 100% of people who screen and enroll in our clinical studies. And, we aim, as I think many people know, to enroll 1,500 people across these studies. And so you screen, well on top of that. And we do see that there is so much nuance to types of hair loss patterns that are not necessarily captured by a traditional scale. Like we use Norwood Hamilton for males, we use the Savin scale in female pattern hair loss. But it is interesting. There's so much variability in what this looks like. And I mean, one of the things we're hoping to do as we collect all these photos is to make them available for research so that people can give us some better answers, right? I think in general, hair loss is an area that has just not been studied sufficiently.
Yeah, I would tend to agree with you on that point. From what I understand, in South Korea, they've opted to use something called the basic and specific scale, where it's just a bunch of various patterns, and you can kind of mix and match them. I think they came out with a new one where it takes into the account the occipital and temporal regions, and possibly diffuse sort of thinning patterns as well. But yeah, that's a very interesting point. And I've also, seen people talk about conditions like DUPA or diffuse pattern alopecia. Personally, I don't know if it deserves to have its own specific category because I'm pretty sure, patterns can kind of, you know, manifest themselves in various ways, even with, let's say like lichen planopilaris or frontal fibrosing alopecia. I read this one paper, I forget the author, um, where essentially you can have something like LPP mimic a traditional Norwood pattern, right? Like
Oh yeah,
at
we call
least
that
along the
fibrosing
hairline.
alopecia in a pattern distribution.
Yeah.
Absolutely.
Yep.
And it's interesting you say that because we do capture that when we screen people for these studies. We do see photos. And I think one of the important parts of the idea that there are mimickers here, in particular in female pattern hair loss, there are a lot of mimickers, is that, if you're losing your hair, don't assume that it's necessarily pattern hair loss or androgenetic alopecia, even though that's the most prevalent. There are other forms of hair loss that require different treatment.
Yeah.
And it's not always as obvious as one would hope. And that's the reason to see an expert, have them take a look at the scalp if you're not responding to treatments in the way that you would think you probably should be.
Yeah, that's a good message. And people really have to not make assumptions about what they have and actually go to an expert and get the proper assessments done because with something like, scarring alopecia, time really is of the essence.
Oh,
So,
absolutely.
yeah.
And I mean,
Mhm.
we see these things progress, unfortunately, in some cases, rather quickly, in particular with CCCA. Occasionally, we see it very progressive.
So, all right, let's let's go back to the minoxidil talk. That was really interesting though. Hopefully you
Yeah,
guys
no, this
enjoyed
is
it.
like my favorite thing to talk. You and I could be here for like 7 hours. There's so much hair conversation to have.
Yeah. So, okay, this part, this I guess section is going to focus on sulfation,
Oh,
and the
yeah.
biology of minoxidil. So, as we know from plenty of studies, minoxidil must be converted by the enzyme sulforotransferase, which is present in the outer root sheath keratinocytes of the hair follicle. And the presence of this enzyme is variable from person to person and ultimately determines response. So, some studies seem to be debating that is, when it comes to oral minoxidil and even topical minoxidil, whether or not local bioactivation is still required. That is, do we still need sulfation activity in the hair follicle for hair to grow when it comes to oral minoxidil? Or sulfation via the liver would be enough to grow hair? And we can see this debate play out between a couple of studies. So I'll just kind of give them a brief overview. The study by Ramos et al., titled, quote, Oral Minoxidil Bioactivation by Hair Follicle Outer Root Sheath Cell Sulforotransferase Enzymes Predicts Clinical Efficacy in Female Pattern Hair Loss, well, that's, we just talked about, unquote, reported that higher follicular outer root sheath salt activity predicted better oral minoxidil outcomes. And this is in contrast to Jimenez et al., titled, quote, Hair follicle sulforatransferase activity and effectiveness of oral minoxidil in androgenetic alopecia. And in that particular study, they measured sulforatransferase activity in plucked hair follicles. So, maybe that might be a bit of a different sort of assay in androgenetic alopecia subjects. And they found that oral minoxidil response was associated with low follicular sulforatransferase. And those that had lower actually were associated with better response to oral minoxidil. And for some more context, Lakshmi et al. 2024 states that oral minoxidil can be effective even in people with low hair follicle sulforatransferase activity, attributing activation to hepatic palate sulforatransferase. And I can just keep going on and on. Ramirez Marin et al. 2022 notes evidence that with oral minoxidil dosing, the platelet, rather, sulforatransferase, and not necessarily the follicular sulforatransferase, can generate the active metabolite minoxidil sulfate, and that sort of supports the efficacy independent from follicular sulforatransferase status. So, after reading all that long-winded summary of studies, my question to you is, if follicular sulforatransferase activity may influence oral minoxidil efficacy, does extended exposure time above the effective threshold improve outcomes in low sulforatransferase patients? And are there plans for a prospective sulforatransferase stratified study or a companion diagnostic to, I guess, guide dosing?
Yeah, so this is a great question and one that deserves a very long answer. So I'm going to start by answering the question directly of how do we think about the interplay between extended release and sulfation. But then I want to take a step back and talk about the metabolism of minoxidil elsewhere, and then talk about these specific studies and where I think some of the data gets misinterpreted in the conclusions. But so the short answer is that we do, right, it is incontrovertible that minoxidil has to be sulfated to have an effect on the hair. And we do believe follicular sulfation is important. Now, importantly, when you think about SOLT1A1 or even SOLT2A1 in the liver, right, these are enzymes that are capacity limited, meaning they can only handle so much minoxidil at once, and they are time dependent, meaning it takes time for someone to, handle or to process the minoxidil into its active sulfate form. And if you think back to the immediate release oral minoxidil pharmacokinetics, the drug spikes quickly, right, overwhelming that capacity, and then is gone quickly, not giving sufficient time. So if you can provide consistent and durable exposures at the hair, we do believe you can drive the activation of minoxidil to its sulfate metabolite and then drive hair growth, accordingly, right? That's a key tenet of what we're doing. But let's take a step back and let's talk about minoxidil's metabolism in general. So, when systemically administered, right, minoxidil is primarily eliminated via hepatic metabolism. So more than 80% of all minoxidil that comes in will be metabolized by your liver. But most of that metabolism is via glucuronidation, not to the sulfate metabolite, where the sulfate metabolite is a minor metabolite, right? Less than 5% of all, administered oral minoxidil will be sulfated in the plasma. What does that tell you? Well, it further supports that idea that it's capacity limited, right? If your body could just rapidly process into the sulfate metabolite, then you would have more sulfate metabolite there. Importantly, that also tells you that when you take minoxidil, yes, you get a liver contribution. And so with systemic, or oral administration of minoxidil, you do get some help from the liver. But there is obviously still circulating minoxidil, and that minoxidil still gets to the hair, and your hair can still then obviously enzymatically convert that minoxidil to its sulfate metabolite. So if anything, you get a little bit of both from the liver and the hair. Now, it raises the question, well, what is the Jimenez article saying? Well, if you look back, and I think it's that study, right, they're using a pluck assay that has a predefined cutoff. I want to say it's like 0.4 OD is like the cutoff at which they
Yeah.
say you're a low sulfater or a high sulfater. Well, if you think about it, that may make sense for topical, but for the oral, you're getting some help from the liver too. And so it may be, right, or it's likely that you need less sulfotransferase to do well. But ultimately, with all of this, you're going to get contribution from the liver, you're going to get contribution from the hair. And the longer that the minoxidil hangs around, the more time for it to get sulfated, and therefore the more time for hair growth, the more time for target engagement at the follicle.
Okay, yeah, great answer. Very elucidating. Let's go on to the next question. I guess it sort of builds off on the previous one. In the future, will Veradermics be collecting exploratory markers? So, for example, hair shaft sulfate base ratio, just as I mentioned before, or I guess just as you talked about just now, plucked based sulfotransferase assay, or much more. I guess we can talk about that, and to link pharmacokinetics to sulfation and to hair counts. Is that something that's going to be, do you guys have the capacity to at least record for some kind of signal to show this?
So we haven't made any definitive decisions on what's to come in the future. I can tell you that in the past, we actually tried to obtain some of those pluck-based assays, and then they'd gotten pulled from the market at the time we were going to use them.
Oh man.
So it is an area that we're curious. I mean, again, this is a drug that clearly has to be sulfated, and we do believe an important part of our story and the potential to drive, fast, consistent, and intense hair growth is the ability to drive the sulfation of minoxidil.
Okay, great. Now let's look at this particular section. We're going to focus on durability and real world performance. So, okay, we've seen 5% topical minoxidil look, I guess, strong early and then level out. But what makes you confident or have, I guess, more confidence in VDP, and whether it will stay meaningfully better at, let's say, 12 to 24 months and not just in the first 4 months? So let's focus on that.
So I think one, we will collect long-term data. So in these studies, patients, will stay in for a year. And so as we get that data, we'll be able to characterize that. Two, with topicals, there are really two unique challenges that are not inherent to minoxidil. They're inherent to any topical product. One is that there is a compliance challenge over time, right? The number of people who can stick with twice daily topical application is very low, even in a study environment. But then two, and maybe more interestingly, and we see this potentially with topical JAK inhibitors for autoimmune alopecia,
Yeah.
is that once you start regrowing hair with the topical, you actually inadvertently make it harder for the topical to work. What do I mean by that? So the hair, right? The reason humans have hair, right, is as a protective mechanism, and it keeps things out. And so if you think about percutaneous absorption, or the ability of a drug to get into the skin that's topically applied, when you regrow hair, you actually make it harder for the drug to get where it needs to go. And so I do think that's one of the reasons why for many topical therapies, like with the topical JAKs for autoimmune alopecia, we don't see the treatment effect we would hope for, is that there really is a drug delivery challenge that in general, right, it would be unusual to try and drug with a topical that deep, right? The hairs can go into the fat, right? They're actually like relatively deep into the skin. Usually
Yeah.
we try get the top layer of skin or the upper parts of the second layer of skin, not the third layer of skin. And then once you grow hair, you make it that much harder. And so I don't think that those are unique challenges with the topical. But again, yeah, we'll generate 12-month data, and we look forward to seeing that in a large subset of people.
Yeah. Thank you. And also it's the aspect of irritation as well with topicals. Yeah, people really, really, hate having to apply this, I guess, alcoholic solution day in, day out that's drying their skin, making some sort of, I guess, dermatitis. That also can make it pretty
It's
hard
very
to
tough.
stick on it. Yeah.
I mean, I think, it's really hard. Any routine in life is difficult, and topicals, regardless of where you apply them, are challenging. I mean, I think there's data that says that 86% of people who start using topical minoxidil discontinue it. And I don't think that is just a minoxidil problem. I think that is a topical problem.
Yeah, I would tend to agree. Now, this is going to be about, I guess, stop restart culture. So if somebody stops for a few months, do they lose gains at about the same pace when it comes to immediate release oral minoxidil or topical minoxidil? Or I guess in the data that you guys have so far, does having been on, I guess, extended release oral minoxidil change how fast results may fade after discontinuation?
Yeah, so it's a good question, and I think, we know that happens in the real world for a variety of reasons. I think the answer today is we don't know for sure, right? We don't have any stop restart data, but we would assume, right, that like with any hair product in general, if you stop it, you are likely to lose the benefit, given this is a chronic progressive condition. I have heard about some people making claims that certain minoxidil formulations have a modifying effect on decay. I just don't think there's any data that's clear that supports that that's true.
Yeah, I would tend to agree. Like you said, for all treatments that come with, I guess, current treatments and prospective ones, you have to keep using the medication to get its benefits. And there are some people who just, I guess, can't seem to wrap their minds around
Well,
that because as soon as they
I
see the
heard
hair
a
growth, they're
really
like, all right,
good
it's done. Yeah.
I heard a really good explanation for this reason. Like I'd never heard this phrase. I had a dermatologist tell me that the way they explain this is that they, ask his, in particular female patients, like, oh, do you dye your hair? And the people go, yes. And they go, well, how long do you anticipate that you're going to continue dyeing your hair? Well, until the gray hairs don't bother me. And it's the same thing with treating your hair, right? That you'll be treating until it doesn't bother you or until you don't want to treat anymore. It really is a similar idea here. And until we are able to genetically reprogram these hairs to not want to miniaturize and then go away, then we will need treatment.
Yeah. It seems like pretty far into the future. So,
I
you
do
know.
think so, unfortunately.
Okay, so let's move on to the next section. So, who actually does well long term on extended release? And maybe you guys don't have the data yet, but I guess in your thoughts, what you can predict, perhaps, who actually does well long term on extended release oral minoxidil alone, given androgenetic alopecia is driven by DHT. So, what is your view on using it with, say, 5-alpha reductase inhibitors?
Yeah, so this is a tough question to answer given that we don't have the data yet. So again, we'll generate that long-term data, which will give, additional answer on who does well over time. I think the question of combination with 5-alpha reductase inhibitors is an interesting one. We obviously haven't done that in the phase 3 program, and the reason that we haven't done that is it goes back to our discussion on the importance of studying monotherapy to be able to
Yeah.
truly evaluate a drug's independent benefit. But with that in mind, obviously they're mechanistically distinct. There's no reason in my mind that they couldn't be used together, and that there couldn't potentially be benefit, right, to combination use, which I think is fairly common in clinical practice today. Although there are no prospective studies specifically quantifying the degree of benefit.
Given how widely off label immediate release oral minoxidil is used, what exposure response evidence suggests that extended release kinetics, not just more minoxidil, drives better efficacy? So, for example, is the improved hair growth potentially due to steadier all day follicle stimulation rather than simply a higher total dose? I think you actually probably already answered this question in one of your previous answers, but I guess
Yeah, one, I
people
guess
might
one
want to
add
have a fleshed out. Yeah.
would just be that with Rogaine, right? Rogaine is approved in men twice daily, right? And when you look at the pharmacokinetics or the exposure of Rogaine, right, you get 12 hours per application. And so, the twice daily showed superiority to once daily because durability of exposure at the follicle drives hair growth.
Okay. And next question. Let's see. You actually answered a lot of these questions earlier, so it's like I gotta find the the more relevant ones. Okay, this one would be a good question. So, have you observed so far regarding? Sorry, what have you observed rather so far regarding pericardial effusion, if any? And what's your plan for, I guess, addressing should this thing ever sort of occur in the Veradermic studies, right? Because I think it's a pretty rare risk just with regular oral minoxidil. You do have some, I guess, case studies showing that at 2 milligram or even 0.5 milligram, some people have experienced pericardial effusion. It could just be by chance, but it seems to be, you know, that oral minoxidil itself and perhaps a genetic predisposition may cause some people to be, I guess, more likely to have that sort of side effect. So I guess, have you guys seen that so far in your
So
studies?
we've seen no treatment-related severe cardiac adverse events. So I guess that's thing number one. But
Okay.
thing number two, and then thing number two is, well, how do you size these studies to detect this sort of thing? So if you think about 1,500 patients, statistically, because each of them ends up on drug over time because it's a crossover design, we would be anticipating that we could detect basically any adverse event that would be likely to occur in 0.2% of the population. So that's how you size these studies. I think it then gets into, well, what's the deal with pericardial effusion in
Yeah.
general? And this is a very complex topic in the derm literature. There was a recent study by Natasha Mezenkovska at UC Irvine that I think really dove into this, where they did echocardiograms. And what Natasha showed that was really, really interesting is that, about 5% of people just walking around have like a small or minimal, pericardial effusion. So open label case report type data can inadvertently or inappropriately attribute pericardial effusion to drug when it may just exist. Furthermore, and I think many people don't realize this because this would never be accepted now. When oral minoxidil was approved as a blood pressure medication in the 70s, that was based on open label data. So meaning they didn't have a placebo group in those studies, which is crazy because
Oh,
you
wow.
couldn't do that these days. Yeah. And it has always raised the question, right? They were studying very sick people with advanced cardiac disease. Did those people just have pericardial effusions because they were very sick otherwise, and you see it in the fluid overload heart failure population, or was there ever really a drug effect? So there's a question there. Now, I think from a what is the drug risk, if there is a risk with minoxidil, what does it look like? I think there is some data that would say maybe it's, that it's exposure related, given that there's some data out of NYU seeing that they really don't see it until doses of 5 milligram and above in a large database, and that they primarily see it in people with predisposing risk factors such as autoimmune connective tissue disease like lupus. So it is a very interesting question. Again, not, we haven't seen treatment-related severe cardiac adverse events, but I also think that pericardial effusion in and of itself is a controversial topic as relates to its association with minoxidil, and comes back to the idea of, historic studies were conducted in a different manner in which they would be conducted today.
Yeah, that's super interesting. I didn't hear about that study, but I just Googled it right now. The one you mentioned from Natasha. That
Yeah,
is very interesting.
super
Very
good
interesting.
study. And I mean, for people who don't follow her research, I mean, she's, one of the top kind of star alopecia experts, and I go to her for advice quite a bit because she sees a lot of hair, she knows a lot about hair, she's a true expert in the space.
That really makes me kind of reevaluate some of the literature that suggests that, I guess, pericardial fusion may be idiosyncratic. So definitely have to definitely have to revisit that.
And this goes to something that I think is a topic that, that is important to discuss. And I think one thing I see, a lot, on the forums, like I think my favorite quote on Trestless is there's this guy who he says, it seems like they're trying to cure our rats of male pattern baldness. And I mean, I think it's a good tongue in cheek comment because like, you see all this basic science data and you go like, what am I actually looking at? Like, what does this mean? And one of the challenges we see in human data, and this includes like human pharmaceutical research data, is that sometimes it's unclear what the data means, right? So one thing I encourage people to do as they look at data is to ask themselves, what are these endpoints really? Like, how are people making these claims? And that for a pharmaceutical product, you need one of these tattoo-based clipped image analysis hair counts and for and a validated patient reported outcome, and that those are the types of data to look for because they have an ascribed meaning, right? They actually, have a significance, and you can kind of know that they're reliable. Whereas I think sometimes you see data and people make statements about something and it sounds really compelling, But if it doesn't tie back to an endpoint that is commonly used, that has been vetted, it's almost impossible to know what it means or whether it's a good thing. And it's something we've seen more recently in the hair space, and it's very challenging because I know people get very excited about new data, and if the methodology in which the data was collected is not very good, or if what was measured is not meaningful, then you have no idea whether the data is good or not.
Yeah, and that goes to the point that your outcomes are only as good as your methodology, and
Exactly.
you know, it's very important to remember. Um, so I guess for because we're talking about oral minoxidil, and it can stimulate hair all over the body. I guess some people have asked me, what about hypertrichosis, right? Like, have you guys noticed any sort of increase in hypertrichosis given the, I guess large overall dose that's going to be used?
So, I can speak to what's, publicly available in the phase 2, which is
Okay.
that, in the male data, we did not see reports of hypertrichosis. Now, with that in mind, if I had to speculate, right, there is a class effect for some degree of unwanted hair growth, right? We see it with Rogaine too, even though Rogaine has low levels of systemic exposure. I think importantly, typically with any minoxidil-based product, the unwanted hair growth that would be anticipated to occur is typically mild in nature,
Yeah.
right? It's limited in nature. It doesn't grow hairs where there aren't hairs that pre-exist, and that there is a mantra that derms say, right, that it's much easier to remove unwanted hair growth than it is to grow new scalp hair. And
Yeah.
I think it's true. I also think the only people who I really saw in clinical practice go off for unwanted hair growth with off-label use of oral minoxidil, were people who weren't getting very good gains on their scalp. Because obviously, if you're not getting scalp hair and then you're not going to take it, but you shouldn't be taking it anywhere if it's not helping. So I do think, well, that was not something we saw in the phase 2 males, and in general, I'm unaware of that really ever being thought of as being a problem in the male population. With Rogaine, it is a class effect, so we would expect that would carry over to a degree. But again, I would tell people that in general, with any minoxidil-based product, it's much easier to remove the hair, right? People shave every day for a reason, than it is to grow new scalp hair.
I certainly agree. And hopefully people can, see the light when it comes to that because, I'd rather, again, I'd rather just shave than having to, do some sort of sorcery to resurrect my dead hair follicles. So, yeah, it's definitely a point. And now for the last sort of question. Many potential patients may already be on antihypertensive therapy. What do you know about drug to drug interactions and I guess the additive blood pressure effects with extended release oral minoxidil? And is one goal of extended release oral minoxidil to reduce excessive blood pressure, I guess, reductions compared with, I guess, other sort of antihypertensive medications? So I guess the question overall would be if someone's already taking another blood pressure medication, is it can they get away with using extended release oral minoxidil?
So we're studying this. So I think a lot of people don't know this, but in our phase through 3 trials, you can take up to 2 blood pressure, medications, as long as you have generally, reasonably control of blood pressure
Oh
on
wow.
those 2 medications. And you go, well, why? Where did the 2 cutoff come from? There's some data to suggest if you're on 3 or more blood pressure medications, you're just very sick, and so your risk of certain events goes up. So we avoid that. The only blood pressure medication that I would, that we think about excluding are things like beta blockers, not because
Yeah.
of concomitant risk, but because of their effect on the hair. So again, as we look at monotherapy, we eliminate things that can negatively impact hair in the same way we would eliminate things that could positively impact hair. And then we do eliminate calcium channel blockers like amlodipine because they have a side effect of about 10% of edema. And given that's something that gets monitored for in these types of trials, we wouldn't want to confound that type of interpretation. But no, it's important to us to study, people who take up to 2, high blood pressure medications, right? People can have high cholesterol in the studies, things like that. People can have diabetes. We do think about these major major common comorbidities and make sure that we can get data, hopefully, that's representative of, what most people who would consider going on a pharmaceutical, what their health is like.
Okay, great. That was a really, really informative response. So thank you for that. And I guess we're at the sort of end of this particular interview. Um, as I always do, what's some career advice you might have for people in the audience? Um, or I guess, yeah, just career advice. Because there are some people who in my audience are actually medical students who are aspiring to be dermatologists themselves, and you seem to be very, very successful. So what's some advice you could give to some of those people in the audience?
I think that the answer is just say yes and explore things until you find something that you're truly passionate about, right? Right, as you mentioned, I'm a dermatologist. I was never intending to go work in the pharmaceutical industry. That was never like a predetermined goal of mine. It happened really by serendipity and really by accident. And what I will tell you, and you hear people say this, and I always thought this was like very trite, and I never believed it to be true until it's happened for me. When you're having fun doing what you're doing, right? When you enjoy it, it does not feel like work. Like I legitimately derive such a high portion of my day-to-day enjoyment, satisfaction, etc. from working. And I look forward to on Sunday, right? I don't, I think we've all been sitting on Sunday and you're going, man, I don't want to go to work tomorrow. I don't ever have that experience. And so I do think that people should really, if they can, try and say yes to opportunities until they identify an opportunity that is unique to them, that brings them joy, because each of us has different skill sets, has different talents, and has different things we like. So what's really amazing for one person, like, and I think anyone in med school knows this, some people like dermatology, some people like emergency medicine. You would have never found me as an ER doc, but I love dermatology. So I think you got to find out what is your area, and then you have to explore within that area, what is it that you look forward to, because we spend so much of our lives working. You want to do something that you find to be meaningful.
Thank you. Yeah, that's a really, really, meaningful response. So I want to thank you for, doing this interview. And yeah, this has been really cool. Thanks.
Well, this was super fun. I'm hoping, obviously we spent a lot of time talking about VDPHL today. I'm always happy to just talk hair in general as well. I mean, we spend a lot of time in this space. We spend a lot of time doing research in this space, and right, we have a commitment to doing high quality hair loss research. And I think that, there's a lot of education that needs to go on about that. And that's why, I love what you're doing. I think it's awesome. So thank you so much for having me. This was a ton of fun.
Thank you.